So just as a forewarning, the microphone does not do its thing inside this room. It's for the purposes of the Panapto. So hopefully everybody can hear me. We're in the back, okay. Well, hello and welcome to our Fall 2024 presentation of the Medical History Interest Group Lecture Series. My name is Molly Frazier and I'm the archivist here at Lapis Library. The Medical History Interest Group presentations are sponsored as a part of the Ruth and John Moskop Lecture Series and the Lapis Library History Collections. If you have not already done so in person, please sign the attendance sheet and help yourselves to refreshments. While you are here today, please have a look at our exhibits throughout the library. Here on the fourth floor, we have Scientists and Their Microscopes, which shows various microscopes in our collections with images of well-known scientists who used the same versions in their research. We also have Medical Marvels, Exploring the Oddities of Healing, which features artifacts from the Country Doctor Museum located in Bailey, North Carolina. Installed in 2018 on our second floor is the Plague of Piracy exhibit, which is a collaboration between Lapis Library and the Queen Anne's Revenge Conservation Lab as part of the 300th anniversary of Blackbeard's death. Lastly, we have our NC Health History and Images photograph collection and Aesthetics of Anatomy art display on the second floor. Thank you all for being here today, and now I'll turn it over to Dr. Todd Savitt to introduce our speaker.
Thanks, Molly. Welcome, everybody. I'm happy to introduce you to today's presenter, my colleague, Sheena Eagan, MPH, PhD, Associate Professor of Bioethics and Interdisciplinary Studies. Her talk, as you can see, is titled Medical Ethics on the Battlefield, the Misunderstood Case of Penicillin in World War II. In addition to her appointment in our Department of Bioethics, Dr. Eagan is adjunct faculty with the Department of Public Health in the Brody School of Medicine. She serves as course director for the second-year medical school bioethics course, faculty advisor to the Brody School of Medicine's Military Medicine Interest Group, and co-director of ECU's Veteran to Scholar Boot Camp, an innovative program she has developed and championed since her arrival at ECU 7 years ago? 7 years ago. Got it right. Before coming to ECU, she worked as a defense subcontractor, providing ethics education to military service members and their families. Dr. Eagan also held a variety of visiting scholar positions for Yale University, the Broker Foundation, and the University of Belgrade. Dr. Eagan holds a PhD in the medical humanities from the Institute for the Medical Humanities at the University of Texas Medical Branch in Galveston, as well as a Master's of Public Health from the Uniformed Services University. Her doctoral studies focused on medical ethics and the history of medicine, with a subspecialized focus on military medicine. Dr. Eagan is the creator and president of the American Society of Bioethics and Humanities Group for Military, Humanitarian, and Disaster Medicine, and has worked closely with the International Committee of Military Medicine. Here is my esteemed colleague, Sheena Eagan, to speak on medical ethics on the battlefield, the misunderstood case of penicillin in World War II. Sheena.
Thank you very much, Dr. Savitt. That bio is very military medicine heavy, as that is my expertise. So I'm so excited to be here today and get to speak to all of you. Today's lecture is, for me, perfect because it's about the history of medicine, but not just about medical history. It's also about medical ethics. So it is exactly the kind of work that I love doing. I love understanding ethical issues, but placing them within the historical context so that we have a more complete moral picture. So today what we're going to do is we're going to re-examine an often told a historical case study about penicillin allocation in the military during World War II. And this historical example, which you're going to be exposed to in a minute, is often used in military medical ethics to talk about something called reverse triage, which I will introduce you to. However, the research that I did with my collaborator challenges the story that has been told in military medical ethics textbooks and in the field more broadly, showing a much more complex picture that is not the simple narrative of reverse triage that is often told. And so before we start, I do want to begin by thanking and acknowledging my collaborator. His name is Dr. Sanders Marble, and he is the senior historian at the Office of Medical History for the Army Medical Department, or AMED. I've been working with him since he was on my dissertation committee, and he is a great source of kind of archival inspiration, and of course has amazing access to archives, being the senior historian for AMED. So let's jump in. Oh, I guess I had animation. My apologies for that. So let's start. We're going to start with the classic case that I'm going to be focusing on for the entire talk. So you can close your eyes. You can imagine yourself in North Africa, in the Mediterranean theater in World War II. It is early 1943, and you are a military physician. You are overrun by casualties at your aid station, and supplies are dangerously limited. There is not enough of anything to go around. And your most powerful new tool, penicillin, that has just kind of come out of nowhere as far as you're concerned, it is in very limited supply. So you're surrounded by injured soldiers, and you have to triage the wounded and decide who is going to receive care. On your left, you have a soldier that has a significant battle wound, a blast injury, and a life-threatening infection. This person can be saved with penicillin, but it would require a significant portion of what you have, almost all the stock of penicillin that you have. Beyond that, since this soldier is so severely wounded, even with treatment, they will require evacuation to a hospital and prolonged hospitalization before they can return to the front line, if they ever can. Next to that person, or on your right, there is another soldier. This soldier has gonorrhea. It's a condition that is not life-threatening and treatable with a very short course of penicillin. And once he's treated, he can return to duty quickly. So you, as a military physician, have to decide which patient you will treat. For decades, this case has been trotted out as the quintessential example of reverse triage in military medicine. And reverse triage, I'll fully define it in a second, but it's something that's rarely, if ever, seen in the civilian world. And so the reason that this case is so widely used in military medical ethics is to show that stark comparison between civilian or peacetime medical ethics, which might tell you to prioritize the person that's most wounded, versus military medical ethics, which is more utilitarian and focused on military needs and military goals, not so much concerned with the people fighting the war. So, according to the traditional narrative of this case, the physician will always choose to allocate penicillin to the soldiers with gonorrhea. And they do this as well as with other sexually transmitted infections, specifically syphilis during this time period, rather than giving it to those with significant battle injuries, because of this utilitarian logic, that they will prioritize those who can return to duty and continue to fight the war over those who cannot. So their goal is not about medical need, it is about preserving the fighting force and winning the military mission. So, just so that we're all on the same page, because I know I threw a lot of ethics words at you in that last slide, I want to pause to talk about some of the key concepts that are going to frame today's discussion. So, triage is the process of deciding who receives medical care first or in what order. Traditional triage allocates resources to those that are most in need. this would be the kind of triage that happens in any emergency department. You know, if you show up with a sprained ankle, you can wait for hours in the emergency room, as those with more pressing medical needs are prioritized above you. Reverse triage flips this on its head. So it's not about allocating the resources to the most medically in need people, and instead it prioritizes those that will use the minimal amount of resources and return to their main function. In military settings, this is often conceptualized as preserving troop readiness or preserving troop health, which is actually the mission of AMED, the Army Medical Corps. It is not about improving health, it is about preserving fighting strength and preserving troop health, looking at it from this population level. So reverse triage, as I mentioned at the intro, it really rarely, if ever, happens in the civilian setting, but it can. There's maybe an argument to be made that there was a little bit of reverse triage or austerity triage happening during COVID-19, for instance. But this happens in times of austerity, so there is not enough resources to go around, and you're trying to figure out how to prioritize your resources in the best way. And this brings us to the ethical theory of utilitarianism. I know all the people from my ethics department know it well, but I'll try to summarize it just in a few sentences. Essentially, utilitarian ethical theory is one that tries to achieve the greatest good for the greatest number. So it's interested in that kind of aggregate good. Utilitarian logic is often used in population-based worlds. It's common in public health, and utilitarian reasoning and logic is often used in the military because of the way the military is structured and its priority to that aggregate. So these tensions, this tension between taking care of the individual patient in front of you that's most medically complex versus doing what's best for the military mission, is really at the heart of this case of reverse triage and penicillin that is always brought up. So kind of getting, were those all the definitions I wanted? Yes. Putting those definitions aside, now that we know reverse triage, regular triage, and utilitarianism, we can look at this classic case that I just read. So the narrative typically goes like this. Faced with limited supply of penicillin, the military physicians were said to have prioritized soldiers with sexually transmitted infections like gonorrhea or syphilis over those with severe life-threatening injuries. The reasoning is that they could return to duty. So according to this traditional narrative, this decision is very purely driven by utilitarian principles. And so you can see why it would be well loved in the world of military medical ethics. It's a very kind of simple case study to use that highlights a foundational issue in military medical ethics. And I have used this case in every intro to military medical ethics lecture I've ever given, every workshop that I have ever done for local military installations, and it was actually one of the first ethics cases from the military medicine world that I ever encountered in graduate school, and that really made me realize, oh wow, civilian peacetime ethics is so different. This military world is fascinating. I should go get a PhD in it. So let's dig a little bit deeper into military medical ethics and really why this matters. So, as I said, this story highlights the tension between those two competing obligations in military medicine. This is sometimes called the problem of dual loyalty, whether military physicians have the obligation to their kind of medical, professional obligations to individual patients driven by the four principles, or if instead their loyalty lies to the military and the aggregate, more global goals of the military that are divorced from patient care and patient health. So, hold on, I'm gonna take a sip of water. So, this story is compelling, right? It makes sense. We imagine the physician that I told you about in the beginning when I had you close your eyes. And you could see that if you're really in the middle of World War II, that it would make a lot of sense to treat the person with sexually transmitted infections and unfortunately let those other people probably die. I should say that in reverse triage and in triage in austere conditions, it introduces a new category of patient that doesn't exist in other triage modalities, and that is the black tagged patient. That is someone who is deemed to require so many resources and kind of be so far gone that they would soak up all of your resources, and you just tag them black, provide palliative care if you can, and allow them to die, sacrificing that individual for the greater good, which is very common in military culture and military ethos. So our research, though, and if you know a little bit more about penicillin during this time, challenges this really simple narrative. And I was approached by my collaborator who was doing archival research on something totally unrelated and came across a correspondence in the Mediterranean theater that really made us question this story that we have been told. So this is how I'm going to structure the rest of the talk today. I know I should normally people start with an overview, but I wanted to start with that case study so you all knew what we were talking about. So we've talked about the classic case of reverse triage in military medical ethics. Now we'll dig into the original research that I've done, but also the contextual research. This is a medical history lecture, so I'm going to give you lots of medical history. We'll talk about the development of penicillin in World War II. We'll also talk about the specific challenges faced by the military during this time, and specifically in North Africa. And then we'll turn to the archival materials to see what they say. So, World War I penicillin. I think to really understand the importance of this case, it's important to understand what medicine looked like before penicillin, because penicillin really was a game changer. On the battlefield, before penicillin entered the scene, a lot of people died of infections. In fact, if you look at the history of military medicine, far more people die of infections than they do of actually being slain by the enemy on the battlefield. Because before penicillin came around, before the therapeutic and bacteriological revolutions that I'll talk about in a minute, we had nothing. And the battlefield was a dirty, messy place. And it meant that basic infections could become deadly very quickly. So this moment in history is also very fascinating because it is picking up on that space between the bacteriological revolution and the therapeutic revolution. So the bacteriological revolution is something that happened, a pretty pivotal point in science and medicine that happened in the 19th century, where we first discovered that it was pathologies, or that it was bacteria that created disease. This undermined these long-held notions about medical theories that were usually humoral or miasmatic theories. So we could now, using the microscopes that are like on display here, we could actually visualize what was causing disease. So now we knew it wasn't just bad air, it wasn't an imbalance in your humors, maybe it wasn't that you had been struck down by God, as that was one of the things that, one of the medical theories. It was these little things that we couldn't see that were making us sick. And even though we knew that, we couldn't do anything about it. We didn't have therapies that would actually attack these organisms or these bacteria. And so we don't see that until the therapeutic revolution, which happens later in the 19th century. And the therapeutic revolution, I think, arguably starts with the advent of salvarsan, which was like an arsenic-based therapeutic that was used but still had a really unsustainable side effects. And so it's not until penicillin comes on the scene that things really change. And this is not insignificant for those of us that study medical ethics, because this really changed how medicine was in the world. It changed the doctor-patient relationship. It now wasn't about just symptom management and nursing care or palliative care. Now doctors could be in the business of curing things. And so that is penicillin. Penicillin was first discovered in 1928 by Alexander Fleming, and I think that that is the person that most people associate with penicillin, but that is not the full story. So the story of Alexander Fleming, for those of you who don't know, it's a good story. He discovered penicillin by accident. So he had a somewhat messy lab, so reports say, and he went on vacation for a couple of weeks, and he hadn't cleaned all of his petri dishes. And he came back after vacation, and as he was cleaning those petri dishes, he noticed that on one there were, and I think he was growing Staphylococcus, I think so. On one of those, it was either that or Streptococcus, I'm sorry to my scientists in the room, but what he noticed is that the mold that was growing, it was in fact killing off that bacteria. And so there was this ring around the mold that the bacteria couldn't grow in. And so he realized, oh, this can clearly kill the bacteria. I wonder what it can do. And he tried his best to isolate it. He tried to grow it in like a meat broth, and he tried testing it with different bacterias, but he gave up on that research relatively early. And it is picked up again in the 1930s by Howard Florey and a team at Oxford. And so, and I should say that Fleming was interested in a lot of things that were kind of like adjacent to penicillin, so he did continue work in the area, but he kind of gave up on penicillin. And then we see Howard Florey and his team in Oxford, and they start to pick up on the penicillin work in the 1930s. And this is a fascinating history because so much of what happened in the Florey lab was happening while World War II was literally raging outside in London. And so they had very few resources. They had a hard time getting funding for their research. They had a hard time getting anyone to really invest in penicillin because it was so novel and because all of the resources were used elsewhere. There was a world war happening. So people were busy. And so Howard Florey and his team end up being able to refine it into a viable therapeutic in the early 1940s. This is a more complicated history that involves them coming to the United States and approaching companies like Pfizer, who were able to develop a better way to ferment the mold so that they could have higher yields and make it into a more viable therapeutic. But in the early 1940s, that's when we really see it be recognized at this antibiotic. So I'll talk about a couple of the experiments that were done early on. One of the first cases where or maybe the first case actually, where they used penicillin as a therapeutic was someone in London who had, there's a couple of conflicting stories, but I would say the most commonly told story is that he was gardening and he scratched his face on a rose bush, and he ended up suffering from a systemic infection that was going to threaten his life. And so they gave him penicillin. And well, they gave him this like penicillin mold broth is often what it's referred to at that time. Not very appetizing, not the penicillin we know today. But he was injected with this mold broth and it worked. And he ended up recovering. Unfortunately, because it was so hard to harvest and create this therapeutic, they didn't have enough penicillin to have a complete course of antibiotics. So this man ended up still dying. And they learned a very, very early lesson about needing to have a complete course of antibiotics to actually kill anything off. So then, I scrolled way too far in my notes. So since, as I said, this was happening during World War II, obviously the militaries around the world were very interested in getting their hands on this new wonder drug that would be able to combat infections. Because as I said, battle wound infections were the leading cause of death on the battlefield. I'll talk about it in a moment, but also infectious diseases, especially STIs, were also a big problem in this moment, and it was leaving us with tons of soldiers in convalescent camps and in hospitals. And in World War II, that is not like the Vietnam War and wars of Iraq and Afghanistan. That is not an insurgency warfare. We are talking about wars of attrition. It is about bodies against bodies on a battlefield. And so you need as many people on the battlefield as you can. So this was seen as a huge kind of national security issue. So to also understand, and this I talked about the great public health images. I love a good public health intervention from this era. The other contextual feature to know is just about troop health in general. So I've mentioned the battlefield injuries, the infections. The other thing that military medicine was obsessed with, not just in this war, in wars previously, was how to control sexually transmitted infections. Sexually transmitted infections posed a dual challenge for the military because medically they were very complex and they incapacitated soldiers for long periods of time. They could not be used as soldiers on the battlefield. Even once we had the arsenic or sulfa drugs, it was still a very slow, painful therapeutic process that took troops off the front lines for too long. And by 1943, there were literally thousands of these cases, and this is just the United States. But the dual challenge that I mean is that this also posed a bit of a moral challenge to the military because of all the moral and cultural baggage around STIs. So STIs, gonorrhea or syphilis, they're of course primarily contracted through intercourse. And when we're talking about the military population, this population is largely contracting this disease in their leave times through intercourse with sex workers. And so this carried with it a lot of moral baggage, which made it challenging to treat. And what's fascinating about the military is that the military really broke off from what the civilian world was doing. Syphilis and gonorrhea, let me rewind, were a huge issue everywhere. And in fact, in World War II, that's when we first saw screening happening for the draft. So the military tried to screen people partially to screen out shell shock and people who weren't meant to be in the military forces. But this mass screening campaign revealed the epidemic of sexually transmitted infections that was happening in the civilian world. In the civilian world, they were still cloaked under a culture of silence, and most interventions were really just fear-based interventions that told, women to keep to themselves and men to pick one, quality woman and only be with her. But the military branched out. They tried therapeutics. They tried very robust public health campaigns, as we can see up here. And I will not regale you with what those therapeutics were early on. I know that it especially makes men very uncomfortable when I talk about the penile injections that they would have to do. But penicillin just changed the game. We didn't know this initially, but penicillin had an almost perfect cure rate for both syphilis and gonorrhea. And this was especially significant for sulfa-resistant gonorrhea, which was becoming increasingly a problem. So even sulfa drugs wouldn't work with that population, and that population would sometimes be hospitalized for up to 6 months for their ailment, which does not work with the military. So the stigmatization, though, of the STI patient or the patient with venereal disease, which is what it would have been called back then, is very important because it clouds the moral picture. When we think back to that case study that I said, it is now not just a service member or a soldier with a battle wound who can never return to duty but might die versus someone with gonorrhea who is fine and needs a little bit of penicillin before he can be back out. It is also deciding fighting between a noble service member who has been struck down by the enemy on the battlefield like a good warrior against this kind of morally corrupt person who was cheating on his wife while on leave with a sex worker. So that really complicated this moral discussion, and in fact still comes up whenever you talk about this case in military medical ethics sessions. People are like, well, I mean, but he did that to himself. You know, this idea of blaming the victim. So the last thing, or a couple more things to talk about just for context, is also the logistical challenges and other issues of mass production in penicillin. I already mentioned just how challenging it was to go from the mold that Dr. Fleming discovered to a viable therapeutic that could be mass produced and distributed. That's, of course, is a huge leap, and we're talking about that happening in just a couple of decades. And in fact, the crazy thing about World War II is that Florey doesn't start his work until the late 30s, and then by mid-40s we have a commercially made, mass-produced penicillin. So it's insanely fast. But it posed a lot of issues at the beginning. One other logistical challenge was, as I mentioned, Dr. Florey and the Oxford group, since they were working in London that was under attack, they literally had to go around stealing things like bedpans from other hospitals to have enough dishes to make the petri dish, or to grow the mold to be able to do their trials, which is why they ended up approaching other people. And once the US government got on board and Pfizer got on board, things ramp up quickly. But even once you figured out how to ferment it and collect it, it's still needs to be brought to the physician in order to administer it. And especially, or in the early days, penicillin needed to be refrigerated. And this is the 1940s. Refrigeration is not what it is today. So it was very hard to bring things that needed to be refrigerated to the front lines. And I think that, or I know that that is an important component, because when we visit the archival materials, what you'll notice is that that ends up being one of the main reasons that penicillin is not available on the front lines. And so it challenges this idea that a physician is at the front lines being like, do I want to give penicillin to the STI patient, or do I want to give it to this person? In reality, someone at the front lines probably wouldn't even have penicillin to offer. And it was located only, especially at the beginning, at specific teaching hospitals or large hospitals. So let's move on to North Africa. So this case study is always happening in North Africa. I don't know why every single version of the case study that I have seen is always, you are in North Africa and this is happening to you. I think it's important to talk about what's happening in North Africa, and also the specific types of battle wounds that we were seeing in World War II. So in North Africa, like everywhere, we have these problems with STIs and combat casualties. One thing that I saved until this slide is that we were seeing blast injuries for the first time in World War II, and blast injuries brought with them, with the shrapnel, dirt and other bad things into the body, which was one of the reasons that we were seeing, I don't want to say even more infections, but such a crazy amount of infections in World War II. So in North Africa, let me make sure I have everything. We have the thousands of cases of gonorrhea and syphilis reported. These infections are knocking out large portions of the population. People are being evacuated for this reason and being sent into large convalescent camps that are back stateside. They first tried to address the STI issue through the educational campaigns that I mentioned, the establishment of prophylactic stations, which is that before service members were going on leave, they received a kind of goodie bag of things that they should take with them and that they should use before and after their night with this fallen woman, which is how they were conceptualized. And I could give a whole other lecture on the gendered politics around who gets blamed for syphilis and gonorrhea, but we'll save that for another day. And then they also tried things like issuing cards and testing sex workers so that they could quarantine sex workers that had active gonorrhea or syphilis and prevent them from infecting the service members. All of that was great, didn't really work, still people had a lot of STIs. So penicillin was very important. So that brings us to the original archival research that I was talking about. This is the piece that caused my collaborator and co-author to email me one day. He was looking through some correspondences and he happened upon this military notice that is dated in late November 1943. So that's very early on in the history of penicillin being used on the battlefield, because we don't see it introduced until early 1943, I believe. So this in all caps, which I love, says penicillin will not, repeat, not be used for the treatment of gonorrhea. Penicillin will be used only for life-endangering infections. And when he came across this, he thought, that's not the story that we've been told. The story that we have been told is that it's always going to the people with gonorrhea because that's what the military wants, that maximizes the fighting force. And so he called me up and he thought, we should do a little research project and figure this out. And so that's what we did. We reviewed archival materials. I'll tell you, these collections are primarily from AMED's own historical archives, and they have a couple of archives. They have like an official archive, and then they have a less official archive, and then there's also a museum of military medicine there that has its own archives. So these materials were pulled from all of those archives by my collaborator, Dr. Marble, and it involved mostly collections of military directives, medical reports from various units and stations and hospitals, field correspondences, and specific controlled study documentation, and that's for something called the penicillin wound study. Some of the most key documents were circular letters from the Office of the Surgeon General that outlined how and when penicillin should be used. And that is also important when I'm thinking back to how many times I've used this in military medical ethics workshops, because it's always presented as being the decision of the physician. The physician is deciding who to give this to. But in reality, this was much more based in policy. And there were, in fact, things that doctors could and couldn't do, populations that they definitely couldn't use it on. And there was a lot of directives and circular letters that outlined this, and they were fairly constant, showing this, showing the growing knowledge that we had about this novel therapeutic and how that knowledge was changing. The other ones that were really interesting were the correspondences from the services of supply, because of course the military is a huge organization. How it gets its supplies around the world is pretty critical to military functioning. And one of the things that's dry but interesting when you're doing this archival work is seeing what is on their formularies, how they're advocating for what goes where. And in this case, it specifically talks about how penicillin can't be sent to forward operating positions because of a lack of refrigeration and because of the fragility of penicillin. Again, undermining this very simplistic narrative that we were presented with at the beginning. So let's visit some archives. Penicillin, when it was first introduced on the battlefield, was very tightly regulated. And I think this is something that's not fully appreciated in the history and definitely not in military medical ethics when discussing this case. So the Army Medical Department began its program of penicillin experimentation at the Bushnell General Hospital in April of 1943. So that's when it starts its formal research into this. And later, in about mid-1943, the studies expand and they establish 2 installations that are training sites or specific schools where military physicians and medics can go to learn about penicillin and how and when it should be administered. Because remember, this is so novel, it's really changing the game of medical care. So these schools were established, and the understanding was that physicians or medical officers would be trained at these schools and then bring that information back to their units. Then when penicillin is made available, they'll be able to administer it and triage it. So then another critical piece of archival data was that Brigadier General P.J. Carroll submitted a really lengthy report to the Surgeon General and this was in late 1943, October specifically, and it outlined observations related to the penicillin research from the Chief of the Medical Services. So this report, which is kind of like research and development for the military, I won't give you the long name for it, but it outlines the success of penicillin as a therapeutic for war wounds, compact fractures, and burns. And it's important that this report isn't disseminated until late 1943. We're talking late October. So that means, I'm talking about the case study, if you're in early 1943 or honestly, even anywhere in 1943, as a physician, you don't even know that penicillin actually works in war wounds because it hasn't been established. It was established already in gonorrhea and in syphilis, and they suspected, of course, that it would work in other infections, but it was a novel therapeutic. It was a scarce resource. They weren't just going to throw it at everyone. They wanted to use it where they knew it would work. And so it's not until October that it's widely accepted that this even works in war wounds and compound fractures. This report also highlights the many logistical issues in making penicillin available for the treatment in forward operating areas, specifically the need for refrigeration, but also that penicillin, when you're talking about a war wound, has to be applied in a specific way. It has to be applied in a sanitary place, so a forward operating medical kind of clearing area is not the spot. That's not nice and clean like a hospital, and that it needed to be used in conjunction with other things like proper wound debridement and a superfine mesh. And so because of all of these logistical constraints, it was again restricted, and it was only allowed to be used at a small cadre of hospitals. This does change quickly because there are hospitals that are acting as training sites stateside, and then an increasing number of hospitals that are doing kind of observational data in the more forward operating settings like North Africa. And so as the war unfolded, we really quickly recognized, due to just the vast amount of of data that we have from all the people taking it, that it can be used so widely. And also at the same time, we're figuring out where it can be used, but we're also getting better at producing it, better at storing it, and better at shipping it. So things really increase quickly. And what you see in these directives is that they start to widen the use fairly early. And I don't want to jump ahead of myself. That I was about to give away the big ending. So, anyway, as the war unfolds, we see 28 general hospitals that were engaged in the study of penicillin in surgical infections. And this is another interesting and unappreciated piece of the story that I told at the beginning, is that the way that supplies are allocated within the military is very prescriptive. Everything is in the military. And for penicillin specifically, they actually had two different troves. They had surgical penicillin and medical penicillin. And it was allocated differently. And so you could have medical penicillin that was for the use of medical officers to treat things like sulfur-resistant gonorrhea and syphilis, and then it was only the group of surgical penicillin that could be used for surgeries related to wound debridement and issues like burns and blast injuries and fractures. So by the 1st of January 1944, we see 16 centers now carrying out forward studies on the treatment of sulfur-resistant gonorrhea, battle wounds, and syphilis. And as a result of all these intensive studies that were both in Army hospitals in the zone of the interior and abroad, it was felt that there was sufficient evidence in order to justify the use of penicillin in overseas theaters and in forward operating positions. So we start to see the military really invest and try to scale up. This period of observation and research also taught people the importance of quick administration of penicillin and how giving penicillin to people with the battle wounds that will become infections, if you can get it to them earlier, it is better. And that did motivate the military and push them to find more creative ways to get it into that forward operating space. So the other problem was the short shelf life of penicillin during this time, and we also see directives that once they recognize that severe wound infections like gangrene and septicemia can be properly treated with penicillin, we see the military very quickly and in all capital letters, emphasize that population. And so they go from saying, oh, you can only use this in sulfur-resistant gonorrhea and syphilis, to now you can't use it in that population. You can only use it for life-endangering infections, and in fact, go ahead and use the expired penicillin on the people with STIs. Fascinating. So we see that in the directives, and all, I think I didn't skip ahead fully. Yes. And so this was a huge changing moment in battlefield injury management. Once penicillin was more widely available, it meant that the number of people dying from battle wounds just plummeted. It went from being one of the main reasons that people die to having very high survival rates. And this was especially true, I believe, for people with amputations specifically. So this brings us to the misunderstood narrative. It turns out that it wasn't all about prioritizing people with STIs over life-threatening injuries because of the military mentality of maintaining the fighting force and doing what's best for the military mission. Instead, you could argue that maybe this is actually a great case of how wartime research should be done. I would say the military is often slammed for, or critiqued, it's perhaps a more intellectual word, critiqued by bioethicists for the fact that they can kind of get around and are able to use experimental medications in their service members. You know, a great example of this is in the Gulf War. We had mandatory administration of anthrax vaccines to our service members, even though it was not proven to work against inhalable anthrax. But we got a nice workaround around that because we're like, it's war, we need them to be protected. We'll just go ahead and inject them with that experimental thing, and I'm sure it will all work out. So that is the main critique of the military. In this case is so interesting in that it actually shows a very methodical, kind of cautious, evidence-based rollout of a novel therapeutic. I'm not always one to applaud the military, but it seems like maybe they did the right thing here. And the other thing is that while ethics played obviously a critical role in some of the allocation decisions, there were other more mundane and banal things that were really impacting this decision, and those are around logistics, even simple things like refrigeration that made distributing it, honestly, quite a nightmare for them. But I find it fascinating that there is this persistence of this reverse triage narrative, even in the world of military medical ethics, where you should have, maybe more of a global understanding of penicillin, of the state of the art at that time. But It makes sense because it reduces a really complex situation into a very clear ethical dilemma that forces military physicians to step outside of civilian medical ethics and make difficult decisions. And those of us that work in bioethics know that case studies are never perfect. They always have incomplete information and are usually structured in order to present a kind of clear ethical dilemma that then we can all grapple with. And the ethical dilemma is clear in this case. They are asking people to pick between the undeserving STI patient versus the valorous wounded warrior, and they're asking physicians to pick between individual patients and the aggregate. So it has a clear function, but as I have shown in this talk, it is not that simple. It is much more complex. And in fact, maybe this case shouldn't even be used as an example of reverse triage. Knowing all of this history, it could be better used as a research ethics case or something else. And I wanted to, maybe I'll do it during the question period. I did pull, because this case is used everywhere, including the textbook on military medical ethics that was published by the United States Army in 2003. They have a chapter that's called the Crucible of Military Medical Ethics, Medicine on the Battlefield, and it opens with this case, presenting this is the foundational issue that you are going to deal with as a military physician, and here is a perfect case to make you think through it. I honestly will probably still use this case, and then after we have the discussion, I will then have so many more tangents to go on as I tell them how this is not totally correct. And I think that this story, kind of as I was working on this research in this moment, I think it does really underscore the importance of revisiting history or revisiting often told stories and the lessons that we glean from those often told stories. Because when you engage with the full story, you have the full moral picture, you have all the information, and in this case, the real story of penicillin is not just about allocation, it's not just about military medical ethics and the exigencies of war, it's about a balance of science and ethics and innovation. So with that, thank you very much, and I am happy to answer any questions.
Thanks, Sheena. That's great.
Thank you, Todd.
Lots to think about.
Yes.
So we'll do questions, and I'll run around with the microphone so that it can be heard by others. So, Melissa.
Make it nice.
Did in fact the expired penicillin work on the patients with STDs?
That's a great question. And the really interesting reality is that they had so much specific documentation about every single unit of penicillin that has been given to every single person. People had to write these really long notes about what was happening, and they had to fill out specific military forms. And then when we get that shift of it being widely available, a lot of that required paperwork just goes away. And so I couldn't actually find anything that told me how that turned out. I mean, it kind of activated some ethics bells in me, which I was like, oh, interesting that we're giving the expired drugs to the people that we've deemed morally unworthy. But I would imagine that it worked like most expired pharmaceuticals. They work just not as well, right? And considering penicillin had just even been invented, I mean, I don't know how short the shelf life was, but I doubt it was that expired. And the military still uses expired medication, except now their policy is, one of my other worlds of research is in military humanitarian medical missions, and they'll use expired medication in their humanitarian missions now.
Okay, so do you think the motivation to create this story came from the fact that there was no other place that they had a good story to show this?
Yes, I was thinking about that. I was thinking, who first told this tale? And I think, I mean, if you look at the history, I mean, it kind of makes sense at a very superficial level. And there were other things going on, like there was a whole, because I'm talking about the US specifically, but in the UK, they were also dealing with this issue of how to allocate penicillin. And there is a very famous quote from Sir Winston Churchill where he says it should be allocated according to the need of the military, which is interpreted as him saying, give it to people with STIs because they can return to duty. So I don't know where it popped up, but it is literally everywhere.
Yeah, so that kind of builds off of the question I had is, what is the origins, like where did this come from? Because it seems like the details of the story are completely contradictory to the actual history.
Yes.
You've got the date, you've got the location, basically, right, who wrote the first story? Because according to the details, this never would have happened.
Right, exactly. Or if the version of it happening is like so different than the simplistic narrative. Because like I said, it's also, this was all policy level stuff. There wouldn't have been one physician just deciding who to give it to. He would be directed by orders who he should be giving it to. So that moral dilemma wouldn't even come up. So I did try to look back and see where I could first find it. And what I found really interesting is that I couldn't find a lot of stories that were like mine, you know, like close your eyes, imagine yourself. It was more, most of them just mentioned it, you know, like, oh, reverse triage, like penicillin in World War II in North Africa. And it was just all just referred to as fact, but without citation, which is also very, very interesting. And I'll pull up the one from the military medical ethics textbook, because it's also fascinating in that it just lays it out. And I should say that this entire presentation is from a manuscript that I'm working on to get published in the journal Military Medicine about this. So the big example from the textbook it's just in a paragraph about reverse triage, it says, an example from United States history is the use of penicillin in North Africa during World War II. The decision was made to treat soldiers with venereal disease with the limited supplies of penicillin available, rather than using it in patients with battle wounds, even if the injured patient might die without it. The reasons given were, indeed, the ability to return the soldiers with venereal disease to the front lines to continue to fight, while those with battle wounds would be unable to return, even if given penicillin. So that's how they tell that story. But in fact, during this time period, as I just said, it wouldn't have even been allowed to be used in that population. It would have been tagged specifically for that population. So.
And there's no citation, right?
No. It just is, again, just kind of like put out there as just the historical fact we all know, you know? We all know what happened in North Africa.
Yes. You're mentioning the use of penicillin in North Africa.
Yes.
It continued and intensified in Italy after the crossing over into Italy. There's a book, perhaps you mentioned it earlier, I apologize for being late, Naples, 1943. Are you familiar with that? That's essentially about penicillin used in the war. And John Lewis, his last name was Lewis, he was a British civilian affairs officer, and he was they were receiving, I don't know how, because they didn't have refrigeration, but large supplies of penicillin from the government, and they were using it both on soldiers and the population, because the Germans were still in Italy. They were in Naples, and the American forces, Allied forces, were working up north, and one of the tactics that the Germans deployed was releasing prostitutes who had gonorrhea and syphilis and all that, mixing with the population. So they use it quite a lot. The big problem, however, came soon after penicillin arrived. The mafia got a hold of it somehow, and it was taken out of the warehouses, U.S. warehouses, and even American soldiers had to deal with Italian pharmacists who got their supplies from the mafia.
Wow.
So it's by the way, while it deals with penicillin, it's a beautifully written book. Lewis is a major writer. I'm not sure if I was asking a question there.
No, I appreciate that. And the history of penicillin, I mean, it's so interesting. And the history of penicillin in World War II is really interesting. I find it, you know, when it was finally a viable therapeutic, there was, of course, all sorts of attempts to try to stop the information from getting out. They didn't want the Germans to know that penicillin was available. They didn't want the Germans to get penicillin. And even in the United States, at least initially, they tried to even hide it from civilians, fearing that if civilian doctors and patients knew that this existed, that it would then even further limit the supplies that they wanted to get overseas to their service members.
So I have a question about what physicians actually did. Has anyone interviewed physicians from that time period?
You mean
was
about
there
like
actually
the
a dilemma?
triaging
I'm sorry?
You mean about whether the case
dilemma
I'm talking about?
Yeah, was there a dilemma that physicians faced?
I would say that in the letters and correspondences that I read, they didn't express the dilemma that I've talked about. They expressed the dilemma of not having enough resources, of fighting for resources, and then some expressed the dilemma that they didn't want to give a scarce resource or even treat patients with STIs because of that belief that this is like essentially a divine intervention. You've been struck down by God and punished with a disease because of your poor behavior. So I read more about that, but I don't think anyone's interviewed them.
Just a thought.
And now, I don't know if we could.
My question is close to what you just asked. I'm worried about the concept of dual loyalty that the military physicians were facing at this point, right? Loyalty to the orders that were given and loyalty to their physician, to their patients. So I'm kind of wondering, were there dissent, from individual physicians who said, in our conscience, I'm going to be able to treat my patient, even though the order says, don't treat people with STIs. Did you come across that in the research?
Not in this specific case, but I will say my more global research on military medical ethics has shown that there is, in my reading, my interpretation, a lot of moral distress on the part of military physicians when they feel pulled in those two directions, when they have a patient that is in front of them that they want to care for. And also, most doctors have gone through the same medical education, they have now that allegiance to the individual patient. It was, of course, maybe a little bit different back then. And so, yes, they definitely express distress around why do I have to do what the military is telling me to do instead of what I know is medically best because I'm the doctor? And I would imagine that it was more significant even of an issue in World War II because so many physicians were drafted into the military, so they wouldn't have all that onboarding and acculturation that really gets them like all hoo-ah about the military mission. So I would imagine that it was even worse back then, but I don't know. I mean, dual loyalty, that's one of the reasons that this case is used so widely because it provides that very simple, stark contrast of do you prioritize the military or the patient? i.e., do you prioritize yourself as a soldier or yourself as a doctor? Or are you trying to make it work in the middle?
Okay, so my question is, I just want to know if there is something that the military is doing to change this narrative of, this misinformation. Or is this something that they feel, oh, well, it's out there, so there's nothing we can do. We don't care, Have you come across research that tries to debunk this narrative?
No, not except this one. So I would say that I guess the military is in that my collaborator works for AMED. So I guess he's interested in that historical accuracy and that clarity. But no, there haven't been. But the world of military medical ethics, when you're looking at it from the military side, is very underdeveloped. We do have the Defense Medical Ethics Center and things like that, but having really formalized programs in military medical ethics within the military is very new and not very common. So I don't think that they're even thinking or reflecting about this, I think it doesn't impact their day. Yeah. Exactly, but I care about misinformation.
Yeah,
Daniel?
thank you for the fascinating talk. I was wondering if there are any other examples of reverse triage and that might actually be more historically accurate, and if maybe there could be a suggestion here to maybe you should use this other example, or should they just treat it as a totally hypothetical? And anyway.
I think I need to think about that for a second, because that does, I mean, that kind of gets at the question, if we don't use this case study, what case study would I use, or would we use in military medical ethics to be able to teach this concept and get people to engage with it? And there have to be other examples of reverse triage.
That's where you could interview the physicians and
Find some like better examples. Well, and it's interesting that you even suggest interviewing physicians, because my background when I first got into military medical ethics was that I interviewed physicians for my dissertation, and part of the reason was that I noticed military medical ethics was primarily done by people that were not physicians and not in the military. And I thought, well, this is interesting. What if we're all like hypothesizing about moral dilemmas that actually don't impact anyone? You know, like I could think the problem of dual loyalty seems like it would be significant to me, but maybe it doesn't impact them at all and they don't even think about it. And so I did interview physicians for that reason, and I found out it's a bit of a mixed bag, and it really depended on a lot of the times their entry point into the military, if they had gone civilian medical school and residency and then joined, or if they had been military medical school, military residency and then joined, or even HPSP. So kind of the deeper you're in, the more you align with your military self, instead of always prioritizing the medical self. But now, Dr. Mosley, I'm gonna have to think about what I would replace that with, because you would think another example of reverse triage would come to mind, but none does.
One more question.
But I feel like it's going to come to me as soon as I step away from the podium.
To me, surely all medical treatment of soldiers and less extent civilians on a battlefield, they must always have not enough.
Yeah.
So whether it's not enough bandages, not enough hands,
Right.
not enough clean water, or whatever. So isn't this always happening, just not as dramatically as this case?
Yes. So, I mean, especially when you're talking about war like World War II, but even if we look at some of the contemporary conflicts in Iraq and Afghanistan, resources, there's never enough resources to go around. If you're far enough forward, then you often don't have access to even a doctor. You have like a unit medic or a corpsman or something like that. So it is very true. Austerity and scarce resources, in my opinion, that's really what makes battlefield medicine or medical ethics in war so drastically different than the civilian world, and makes it so complicated for physicians to inhabit that space, because you come from like a teaching hospital where you can have access to whatever you need, you know, arguably in a well-functioning health system and everyone has insurance, then you can have, right. And so we never really saw that level of austerity until COVID, until all of a sudden we had to be allocating vents and thinking, well, can we put this person on this vent because they'll need it for 6 months when we could give it to 3 people that each need it for 2 months. And that really was a paradigm shift that the military has always kind of grappled with, but that civilian medicine hasn't had to. And then triage, because that's reverse triage. Triage in general is one of the biggest issues in military medical ethics because it looks so different than civilian triage. Civilian triage is, you know, it's about priority and who will be seen first, but there's the understanding that there's enough resources for everyone to be seen eventually, and that's not the case always in the military. And then there's more complex triage issues around what do you do? In this scenario that I presented to you, it's all your men, but I could present to you a scenario in which you have an enemy combatant that needs the penicillin for a battle wound to survive versus your own man with an STI. The Geneva Conventions would say they're all equal, they're all wounded, they're outside of war, it doesn't matter, but that's not how military medical ethics really functions all the time. And that was a tangent, my apologies. Thank you.
So I was thinking, this was a great way you wove history and ethics together, which was terrific, and also introduced many of us to concepts that I don't think we've thought about before, the difference between military and civilian worlds, and especially in medicine and ethics. So, and to think it's 80 years ago or so, 1943. So not that long ago, although.
You want to rewatch the movie MASH or the television series. They were dealing with this tension.
Yes, definitely.
So welcome to come talk to Sheena or have some more food and drink, and thanks for coming.
Yes, thank you for coming. Thank you, Todd. I didn't know you were going to introduce.